Although Zimbabwe is one African country that has achieved a significant decrease in HIV and AIDS, there are 1,100,000 people still infected with HIV. 369,431 adults and 39,234 children are on antiretroviral treatment, or ART. As more people living with HIV are witnessing the benefits of ART, more are coming forward in numbers to access the life-saving medicines. Initiated in 2004, the ART program, which started with only 500 patients on treatment, has grown to cater for 408,665 adults and children in 582 initiating and follow-up sites nationwide. This is so as to address issues of equity and effective coverage of ART services in the country. The program has performed well, and preliminary results from an ART outcome study by the Ministry of Health and Child Welfare indicate survival rates of about 91%, 78% and 69% at 6, 12 and 24 months respectively. The Zimbabwe National Network for People Living with HIV, ZNNP+, as the national umbrella body that represents and coordinates the interests of support groups, has been advocating the availing of the ART program to all those in need of treatment.
People who've been affected and people who've been infected with HIV or AIDS can and should actually live normal lives as like any other person who is maybe infected or suffering from cancer, or somebody who is not suffering from any particular disease at all.
Timothy Sandram, a ZNNP Plus member from Kwazana, tested positive in 1998. Through the ART program, he recovered and was able to live a normal life, later meeting his wife.
Patime yacho iyoyo ndopa ndakazwanawo uyu manje support group ndokuchitiwo ndiona ndindega kandoda mubatsiri zvikanzi hazvina mhosva nini vanga akashayikirwa ka zvikanzi nini ndodachi apangane vana vake vairi ndine vairi saka zvakazongoitikawo ndobva takurumidza kuenda kunotaura kupi kuchipatara. Tataura kuchipatara ndokuchinzi sezvo wane pamuviri hazvinetsi kana wazosununguka paunosununguka ipapo mwana tichamupa nevarapini, then imi mamai mapiritsi amuri kumwa kudhara vaimbopuwa nevarapini kana vakunosununguka, but vainzi mapiritsi amuri kunwa izvi zvari right kana mune pamuviri, imongoramba muchingoita se muchidzivirira. But challenge yatakazowana ndeyekuti vane pamuviri ipapo pane 2-3 months vakazorwara TB yechest kunge ndakamborwara, ndakamboda kunetseka patati kuna chiremba hazvingati affectire mwana iyi, zvikanzi aiwa hazvina mhosva tichava treatment yeTB wopedza wokontinya chimwa mairafi yavo kusvikira vaita sei vasununguka. Saka pavakasununguka mwana apapuwa nevarapini yake 1 month, vapuwa inozvarupuwa court things for 6 months iri kana singakanganisi kuti aramba achimwa nomudzivirira kuti asaite chirwere.
Ndiri right, ndakasimba. Dambudziko randinongosangana naro ndere mwana, nokuti mwana akuda kudya chikafu chakawanda, nokuti mukaka waari kumwa haso hausi kumukwanira. Saka chandinongoda kuti ndingomira kungoti 6 months dzikakwana ndomupa chikafu chakawanda zvokuti pamwe angagute akapfurikidza izvi zvaari izvi. Pamapiritsi angu ndokungonwa handisi jambe, nekuti zvinonzi ukazojamba kunwa mapiritsi aya zvinozokonzeresa mwana kuti aite zvisirizvo. Saka mapiritsi angu ndinotonwa nenguva, handina musi wandakambojamba, ende mwana wangu ndinomupa court every nguva dzese, ende handina zvimwe zvinhu zvandiri kumbomupa kunze kwemukaka iwoyu, ndondinoedza ndichimupa kazhinji.
Timothy is not an isolated case, as demonstrated by members of Yamarai's support group, who are also beneficiaries of the ART program. People living with HIV are now able to live normal lives and are embarking on income-generating projects. We take a look at Yamarai's support group.
Tikutofara nazvo nekuti ZNNP iri kutidzidzisa zvimwe zvinhu zvakawanda. Inotitsigira workshop atinenge tichiita takaita nutrition demo ZP Plus takaitaurira ndio vatakapa tsamba yedu vakatanga kuronga nesu kubva pekutanga kusvikira tiite nutrition demo iyo yakanakidza zvokutoti tida kuita imwe pamberi apa
tichiri kutanga zviri kusumukira gozi second year third year i-third year yedu asi ndikuona kuti zviri nani saving taakugona kusevha dhora tinosevha toligona kurishandisa kuti tosevha sei kubva pamugadheni papa ndopazvakatangira pagadheni apa
vachinja musupport group medu ndezvokuti isusu kusvika tomakansera takutokansawo vamwe vanhu kubva musupport group kurasi pfungwa hatichisina mastress kana uri wega pfungwa unostresseka.
Support group yedu isusu takaronga machi muno takaita awareness match takafamba muno mumusha takabata bhana redu tichinyatso disclosure kuti ndo zvandiri hameno zvako iwe wakawanda pasi pesaga uchafa wakadaro. Takafamba takaita machi tichitsigirwa nedhisenda nemashambanzou muno mucommunity medu muno. Saka kubva patakaita machi iyoyo takafara zvikuru nokuti vamwe vainyara vaivaeka takazoona vakuya kwatiri vakuya akatanga kuya akataka kuhwanda so asi izvizvi tine mugadhono.
Despite Zimbabwe having recorded successes in efforts to curb the HIV epidemic, economic hardships and donor fatigue worldwide have led to the opening of another era of problems. There has been a steep decline in donor funding. The Expanded Support Program for HIV and AIDS, ESP, was introduced in April 2007. This was a basket funding mechanism introduced to support the national response to the HIV and AIDS epidemic as guided by the Zimbabwe National AIDS Strategic Plan, ZNASP-1. The funding partners for the ESP were DFID, Irish Aid, Canadian International Development Aid, Swedish International Development Aid, and the Norwegian Embassy. The ESP covered all components of the national AIDS response, with a bias toward treatment and care. Initially, the target set for the ESP support was 16,000 patients on ART in 2007. However, this increased to 80,000 patients by the end of December 2011. The ESP lifespan came to an end at the very same time. Because of his blindness, Dick has often experienced discrimination from his peers. He is homeless and unemployed and currently has to sleep at the home of the secretary from his support group, who also struggles to make ends meet.
Uriyo ndichingodyawo zvavanenge vachibika kana ndikasvika mumba memumwe nemumwe andongozoti aiwa mumwe wedu haana pekugara. Pamapiritsi ndiri kuawana zvokundishandira nekuti zvandakange ndiri nezvandave zvinezvi zvatosiyana. Pekugara ndo pari kunyanya kundinetsa pekugara zvokuti ndaida kuti ndikaonawo pekugara ndinokwanisa kuti ndikatorawo mukadzi ndinokwanisa kugarawo naye pamba ipapo semunhu akaremara asingaoni mumabasa. Nyamo ndinotadza kushanda mumabasa nenyaya yekusaona nekuti ndine license rangu class 2. Saka kuti uone murungu anokutora usingaoni maziso hakuna munhu anokutora. Nditori driver pandiri pano saka nditokwanisa kutoshanda mese mandinoenda. Ndiri plumber futi by profession but handina anokwanisa kunditora ndive ndinomushandira nekuda kwemaziso. Ukaenda pamurungu anokutaura kuti unozozvikwadza kana kuti unokwadza nemushini.
Asi dambudziko hombe nderekuti vana ndine 2 vari kuenda kusekondari. Wana ndakatarisira kuti aende grade 1 gore rineri haana kuenda. Saka ndine shuwiro rekuti gore rino aende grade 1. Vamwe vaviri vaendeswa nababa sekondari ende inozvi baba vashaya handizivi kuti ndichaita sei. Ndeni kuti ndiwane mari kuti titenge chikafu chatonyatsonzwa kuda kudya because munongoziva muZimbabwe sadza nemabheji inoda kutombochinjawo tingochi kana kanyama. Izvozvozvo zvinokonzerwa nekuti ngadai ndawana basa ndikawana basa ndokwanisa kungozvitengera zvandoda. Ndodambudziko hombe chete. Ine ndiri fiti handina panondorwadza. Nyange ndikaona basa rinonzi rinoda varume nditori murume mungozvionera ndakatosimba azvingandombotorwadzi ndotoshandawo ndotomhanya nevamwe ndodambudziko.
Machinge District Plumtree is one of the 4 communities where ZNNP Plus conducted community leaders forums. Several issues were discussed. The people cannot access drugs and some simply cannot afford them, while others cannot walk long distances as they are sick. The only mode of transport for the few that can travel are Scotch carts. Gogo is HIV positive and has no one to take care of her.
Vayenga muzosala nako
ndinagwe vakati ndinagwe vakanditola malo
ndimwe munonwa maphilisi
ndimnomwa maphilisi manje vanti hati manje kova kuti se mudala wangu akafa ntolo ndakagowa naye vakati mungamungudza vana musina magilavhusi atakuli kuti gotogwa nonono vangena mumatransipoka ndizvoke ndomwali maphilisi manje mwakasiya vatatu mwakasiya umwe mpeli manje vazvadzi vavo avatoha munhu imi ndimi ndinodzila navavo vana ndodla zvinolema ndo vanofunda zvinolema zvakwamunovona vanhu takatsvigwa nomuba kuna.
She fell into a fire and has burn wounds all over her body. She eats amateha, a bark peeled from a tree. With the issue of funding making the headlines daily, one wonders what the future holds for people living with HIV. Already they have begun feeling the pinch, as accessibility to ART is becoming difficult. Some live far away from clinics, and most of the time do not have the bus fare to travel for treatment. The consultation fees of $5 at clinics are unaffordable for most. There also have been reports of drug stocks running out in many locations in Zimbabwe.
I think the starting point is the issue of health. Health, you remember when we talk about the MDGs, one of the most serious challenges that we're facing, perhaps nationally to begin with, and then perhaps coming down to the district, is resources to ensure that people are close to the health facilities. The challenge in Bulilima is that the health facilities are far apart. Government and then the local authority have between them 17 health facilities. Perhaps we're talking about, if you're talking about Bulilima, we're just talking about 2 rural hospitals, and the remainder are just clinics. So I think that's the first challenge, that people walk long distances to this health facility, and I think it discourages those that would have to use Scotch cars to come here. If they come here and find that there is a drug shortage, then next time they think they may as well not even come.
Availability of drugs. Maybe sometimes people come here and they are turned away. There is no medication and things. It might cause even deaths. If a person is sick, what he needs is medication, isn't it?
Ndiri kumboti vhiri ngeizvishoma ndezvokuti rimwe zuva tinopiwa date radhokta toti ari kuuya musi wa6 pedzisirezvo wanzi dhokta ari kuuya musi wa10 saka panenge pachitori nekamukana kasinganyatsoita.
The challenges we have the projects, but we don't have enough funding to start up our projects. We have gardening, poultry, goat rearing, sewing projects and whatever. Then at last I just read they first of all go to the council gives them the ones to work with. So unless the councillors step up and really support us with funding projects, what we think is that no HIV projects are funded. We always send project proposals to different donors, but we are not really replied.
Zimbabwe was among the priority countries for the Global Fund's R11 submission of funding proposals, after having been unsuccessful in the R10. Beyond 2014, there is uncertainty about the continuation of Global Fund support. ARVs, unlike other medicines, need to be taken for life, as failure to do so results in development of HIV drug resistance. Once we have a drug-resistant HIV strain, it will be difficult to contain the epidemic and the country will be worse off. Second-line ARVs are about 6 times more expensive than the first-line medicines. Failure to treat HIV would lead to an increase in HIV transmission through heterosexual contact and also from mother to child. AIDS-associated morbidity and mortality would increase, leading to loss of productivity and weakening of economic performance. The consequences of failure to provide HIV treatment will seriously derail the country's efforts towards universal access to treatment by 2015, the elimination of pediatric HIV by 2015, and the overall HIV and AIDS epidemic in the country.
I would actually appeal to the people of Zimbabwe, of course through the government of Zimbabwe, if we could increase the allocation into the health fund, like there's been the Abuja Declaration, which says at least 15% of all money collected by government should go towards health activities. We would actually appeal towards that. I would also appeal to the National AIDS Council of Zimbabwe to review probably the amount of money being allocated towards art. Currently, we are where it is at 50%. Maybe if they could gradually increase that money, hopefully to as much as 75%, maybe it will actually cover us quite a lot. We're also appealing to the donor community. We appreciate there's donor fatigue, but we are saying for Zimbabwe, please let it be a special case. The incidence of HIV and AIDS is still high within Zimbabwe, and it's only through their mitigatory financing that we'll be able to actually maybe stabilize or even reduce the incidence, if not even totally eliminate HIV and AIDS within the country.
However, with positive minds, communities are empowering themselves through home-based projects. They are freely holding outreach campaigns within their communities and making an impressive impact as they educate the masses of HIV and AIDS.
The Ministry of Health, they have actually taken us on board. It's an issue of maybe conscientizing one another. We're working with the Ministry of Health, we're working with the other ministries as well. We're working mainly through the National AIDS Council as well. We are exploring what we have referred to as the MIPA principle, that's meaningful involvement of people living with AIDS in all activities. We've also said nothing can be done for people living with HIV and AIDS without them. So it has to be a participatory process whereby for planning, people living with HIV and AIDS have to be brought in. Then we actually plan, we come up with ideas and we implement together with ministry, with NAC, with anyone else, but we involve people living with HIV and AIDS.
But we are encouraging these people now to, as a way forward, to build clinics. And as we're speaking now, there are about 2-3 communities that have already come out with initiatives of their own to build clinics. Just as of yesterday, I was handing over a clinic plan to one of the local authorities, to one of the locals who are about perhaps 10 kilometers from where we are here. And we are encouraging more of those people. And how we are doing this is that we are asking the local guys to do the molding of bricks, whilst those in the diaspora, and when we talk about diaspora, we talk about those who are outside the country, mainly South Africa, to raise funds for the builders. And we as council are also coming very close with raising funds to ensure that we match the initiatives from the community.
As it is, we have made a plan with the field officer that we are from this exercise, we are going straight to the CEO. I don't know, as he was talking, whether he will support us. Through his talking, and he has already said we are discriminating ourselves, stigmatizing ourselves. I don't know whether he will respond, but we are going to list down really our needs. I don't know whether he will respond.
Kinyana, angazo wa kinyomu.